Read the chapter number 101, that is psychiatric distress and resilience. Now, very important chapter. So, what is the cause of distress? Like all other problems, it is multifactorial. So, distress is due to diagnosis, treatment, outcome distress, distress of relapse or failure, and even no failure, survivorship distress. So, all phase of treatment has distress. Then the distress is related to loss of function, loss of employment, loss of social circle, and sexual life. So the personal losses and social losses all lead to distress. Finances, major distress. Uncertainty about self, uncertainty about family, children, again distress. So these all distresses, this manifest like, the manifestation is variable. So sometimes it is manifestation from this sadness to anxiety to depression to even suicidal tendency. The manifestation depends on the personality, the coping mechanism, the spirituality, so everything. So distress in nutshell is a multifactorial thing, and manifestation is mired with variable things. So if we define distress, so let's see the term that is multifunctional, unpleasant, emotional experience of psychological that has cognitive, behavioral, and emotional. So psychological, social, and or spiritual nature that may interfere with the ability to cope efficiently with cancer, its physical symptoms, and treatment. And in that extent, along a continuum varying from sadness, depression, anxiety, panic to spiritual and existential crisis. Now, this is the heavy definition of distress. So, NCCR also quotes this. Let's decode the definition. So, first, it's a multifactorial, multifunctional. Okay, it's an unpleasant emotional experience. That's the root thing. So, it's an emotional thing, unpleasant emotional experience of psychological, social, or spiritual nature. So, the distress is not a physical parameter. Distress is a psychological parameter having a psychological, social, and spiritual nature. And the extent, everybody having some distress, but it should be of the extent that interfere with the coping ability, cope with cancer, symptoms, treatment. So it interfere with the planned care, interfere with the diagnosis, understanding, and the care. Now, it has continuum of presentation like sadness, depression, anxiety, panic, and then many other like worthlessness, helplessness, and spiritual and existential crisis. So this is all distress definition. Now there are many tools how to measure tools to screen distress. There are many tools. Questionnaires are there. So we must know some names. Patient health questionnaire 9. That's one. HATS, very important. Hospital anxiety and distress scale, then promise and Beck anxiety inventory. So the most appropriate for hospital this cancer is heads. Heads, let's have some idea about heads. It has two components, anxiety and depression. This, yes, depression, not distress, depression. So depression. So one is anxiety, one is depression. So heads is having only psychological thing. Psychological assessment only, not a physical assessment. So not confounded by the impact of cancer, like weakness, inability to walk, nothing to do with that. It has 14 items divided in two subsets. So one is anxiety and the other is depression. And this subset has each question has 0 to 3 score. So final score in each subset will be 21. So 0 to 7 is normal, 8 to 10 is borderline, and 11 to 21 is significant. So significant depression, the heads score is 11 to 21. Significant anxiety, the heads score is 11 to 21. So there are two different parallel things are going on. Now when we look for Beck anxiety inventory, it's the most extensive one. It has 21 questions, which is psychological as well as physical. So actual these are the physical manifestation of this distress. So the questions are like trembling of hand, uneasiness, breathing difficulty, numbness, warmth. So these like fatigue, fear, panic, these questions are there. Each question is from 0 to 3. This scoring system is there. So the score once comes 0 to 7 is normal, 8 to 15 is mild distress, 16 to 25 is moderate distress, more than 25 or 26 or more, it is severe distress. So this Beck anxiety inventory is also there, which based on physical finding of the distress. Now heads is the most appropriate for oncological patient, anxiety and depression scale. So these scales are used to find out whether the person is having distress, anxiety, depression, these things or not. So what is the common continuum what we are discussing? So in the continuum of distress, what all the patient can have. So he can be depressed, so depression, anxiety, stress related problem like panic attack, phobia, post-traumatic stress disorder, then adjustment disorder, delirium, neuropsychiatric problems. These all can happen. Now, if the person is already having a previous psychiatric history, female sex, poor social support, uncontrolled symptoms, or he is a personality of like this prone personality, these are having more chances of these manifestations. Earlier the diagnosis was with this psychiatric terms like this DMS 5TR, this coding system was there, but now they say it's not required in oncology because it keep on varying. So putting a diagnosis of schizophrenia in a oncological case with distress is not good because it can improve, it can worsen. So anxiety, depression, mixed of that. So it's more advisable to put the level distress and explain the distress. Now there are some red flags also, which you must know in day to day. It's not uncommon to find. So if a person is remembering too much, or occupied by his or her disease, like the first consultation, first dialogue of diagnosis. So, or the person is having decreased sleep or increased sleep or intrusive thinking, lot of thinking, denial, So these all are flags. These are flag that okay, the person is having distress. They must be screened and accordingly helped. Now this distress in acute form, not taken care, they can convert into chronic distress, leading to depression, anxiety, post-traumatic stress disorder, personality changes. So cancer diagnosis and treatment changes the personality is often seen. There is one positive finding out of all this, that post-traumatic growth. So what is post-traumatic growth? With the diagnosis and with the shock of the diagnosis and treatment, the person become more wiser, planner, spiritual. So they start believing in God, thankful to life. So these are a wise response to this distress, and these people are managing or coping distress very well. Now, why we are worried of distress? Okay, so ultimately this distress is causing interpersonal problem with caregiver. The distress is causing interruption in treatment, poor compliance, then suicidal tendency. So this suicidal tendency is much important thing. So 4.4 times higher tendency noted in cancer patients, and in this even survivor has high tendency even till 30 year post treatment. So that the psychiatric algorithm in brain is somehow disturbed. So the suicidal tendency is always high with them. Now, whenever we are finding any red flag for suicidal tendency or any of the psychiatric thing not getting managed by oncologist, it is important to enroll a psychiatric person, psychiatrist, social worker, clinical psychology. So these all make a team for distress management. Now NCCN clearly says that in US it is imperative to have a team for distress. It is advisable to screen for distress at every visit. So, and if there is any red flag from the clinician side, incorporate all the team members, the psychiatrist, the social worker, clinical psychiatrist. So the suicide or the further worsening can be prevented. Now, suicidal tendency red flags are again depression, this loss of compliance, loss of social support, existential crisis, not talking. These all are problematic things. Now, how the person is coping? So coping is when we have a problem, then person start behaving in certain way to mitigate the problem. So this is coping is adaptive response to new challenge. So cancer is a challenge, the treatment is a challenge, so everybody has coping mechanism. For a coping thing, we need three type of coping help. Information. So this is information focused, give them information, emotion focused, and problem focused. These three components of coping is there and all must be addressed. So let's understand what it is. Information means the person want to know about the things, what is going on, what is the plan, how we are going to do this. So the information of treatment, information of outcome, everything they want to know. Giving the information help them in coping with the diagnosis and the treatment plan. Then emotion. Just listening to the patient or extending the help or a social worker doing that is an emotion. They have fear, panic, anxiety, everything. So emotional coping is there. Then ultimately there is problem solving coping. So the wiser part, the person want to be a part of problem solving team. So the doctor must help the patient in coping. He should not or she should not be left alone to cope with the diagnosis. Just telling the diagnosis and then okay, you come after 3 days. So whole 3 days he will struggle or she will struggle coping with the information that is half cooked, no plan, and there is nobody to give the emotional support, and he or she is not aware of the solution also. So the problem part is also missing. So this coping mechanism must be kept in mind. Now, see what happened when we are giving this initial diagnosis. The distress is in the form of existential crisis, and they need maximum support here. Okay, the existential crisis, whether I am going to live or not, helplessness, leading to this fatigue, disruption of social and sexual life. So these things happen with the primary diagnosis. Now, what is the solution? Counseling, group counseling, family discussion. These all three type of thing has been found beneficial. So once the acute phase, so initial diagnosis and treatment phase, we want to help with individual, group and family counseling. Now this end of acute phase, so the person is having sense of vulnerability, fear of relapse, fear of long-term side effect, so and medical isolation, very common. So tag of cancer patient is there. So these things are common. Now how to deal with? So they must be given a treatment summary and follow-up plan. So that's helping by problem focused coping. So treatment summary and follow-up plan must be discussed with the patient. Then there are survivorship, this plan. There are survivor group that the person can refer to discuss each other's problem and achievements. So end of the active phase or treatment phase, this type of help can be extended. Now coming to once relapse is there. See, relapse, whether we like it or not, but significant number, almost 1/3 is getting relapse. So the relapse has anxiety, manifold increased uncertainty, truncated future. So the future looks bleak, and loss of social contact. So how we can help? We can help is reordering priorities, group counseling, then giving a clear communication for care plan, compassion. These things can be done by the clinician. So what we have seen, the different phase of treatment. The coping is by information, emotion and problem. So these should be helped. Initial diagnosis and treatment, the problem in the existential crisis, helplessness, fatigue, depression, even denial. So the counseling, group counseling, family counseling is done. End of acute phase, the survivorship counseling, and the better to let them join the group. If relapse, reorder the priorities, group counseling, compassion and commitment of care, like we are there with you, is important. Now coming to interventions. So if a person is having significant distress, this till now we are saying that what we should do, anticipating that the person is having these things. So this will make their journey smooth or distress free. If a person is having distress, then the treatment is required. So the treatment, first thing is psychoeducation. Most important part. It is the psychological counseling as well as providing the education regarding the thing. So start classifying, identify the distress. Identify distress, classified like anxiety, depression, psychiatric, schizophrenia. Then first identified, then you look for need of medication. So pharmacotherapy, need of psychotherapy, and then selection of treatment, selection of intervention. So what we have to give. Now psychoeducation is education also. So involve the patient in by educating them about the disease, about the distress, assuring that this is common. So again, we are going to help them in coping by all the three, that is problem solving, emotional, and this information. Then problem solving therapy is there. So this problem solving therapy is type of behavioral therapy, which is very important. So define problem, let them define problem. So discuss solution, reassess after doing this. Better done in group. It's a part of group activity. Can be done individually or diets, that is 2 persons. So group activity or these things are part of psychoeducation. Second is psychotherapy. For psychotherapy we have this cognitive behavioral therapy. So cognitive behavioral therapy is training the brain to stop overthinking, to self-directing for a better thing, distraction, self-hypnosis, relaxation, these things are taught in CBT. Then there is ACT, ACT. ACT is acceptance and commitment therapy. This is more robust, okay, with the sentence like be a man, you have it, accept it. So accept and you start committing yourself for the treatment. So ACT is a more practical approach. Accept the new normal. With that, we derive new normal. So this is the diagnosis, this is the treatment plan. There is no other way to escape. You have to accept it and do the thing. The third is mindfulness. This is a very good concept when mindfulness is putting your whole brain and whole focus to the thing what you are doing. So it is good for relaxation, stress, like mindfulness based stress removal or reduction, then breathing, even eating. So this mindfulness can be done. Now this psychotherapy can be done in group or individually, and when we are doing in group it is more effective. So it helps in making the bond, feeling that everybody is in the similar boat. Now for the group discussion we must include this social support, emotional support, detoxifying death. So not to be too much concerned of death and other thing. So the group discussion, keeping the death discussion is simple. Okay, so detoxifying death. Then organizing life priorities. Asking them what you want to do, what is your 10 desire, your 2 desire, your 5 desire. Increasing communication. So group discussion breaks the barrier also. So there are advantages of group discussion. Now there are enough scientific evidence that a psychiatric or psychological support improve overall survival. So a single lone person die early for the same disease when the family is around. Psychological help extend life. So it's not only quality, the quantity is also improved with the psychiatric help. Now coming to use of technology. So it is not possible for everyone to come for these sessions. So there are mobile and internet based technology for self-screening of distress, for motivation, for mindfulness, for tracking the progress, and sleep pattern, sleep trackers. So there are many available app also like Headspace, Reverie, Live Strong. These apps, they help in all these self-screening, motivation, mindfulness, tracking the progress, sleep trackers are there. So these technologies are also helping. Now coming to pharmacotherapy. So the caution is some pharmacotherapy medical oncologists can use, but be aware that whenever there is a red flag, the person is having suicidal tendency, the not improvement is there with the pharmacotherapy what we are using, it's always advisable to refer or to include a psychologist or psychiatrist in the team. So we have multiple groups. The antidepressant. Now in antidepressant, we have this bupropion. So 75 mg to start with. It can go up to 300 mg per day. Then we have citalopram, 10 mg to start with. We have citalopram, 5 mg usual dose. Duloxetine, 20 mg usual dose. So then there are other agents also. Sertraline, trazodone. So these are commonly used agents which you will find in ward. Then we have tricyclic antidepressant under the heading of antidepressant, and they have amitriptyline, nortriptyline, imipramine, doxepin. Only beauty is each one is having same dose, 10 mg to start with. Now the cumulative toxicity is there. Anticholinergic side effects are there. Then we have the other group, anxiolytic, for anxiety. So not for depression but for anxiety. Lorazepam, 0.5 mg initial dose. Alprazolam, 0.25 to 0.5 mg. Then we have clonazepam, this zolpidem, gabapentin. Anxiolytics. So, and we have antipsychotics also. So person is having the psychiatric disorder like schizophrenia, so and severe panic disorder, then antipsychotics like haloperidol, commonly used, olanzapine, quetiapine, aripiprazole, risperidone. These all are commonly used drugs. So the pharmacotherapy, this all psychiatric drug can be started based on their requirement, but it's always advisable to watch they are just masking or whether they are improving it. The person may become suicidal, and it's not only ethically important but also legally important. If the red flag of distress is there, we must involve a psychiatrist in the care. Otherwise, it's whole care. If it abruptly ends with the suicide, it's morally, ethically, legally not safe. So this is about the chapter, this psychiatric distress and resilience